All right, everyone. This is the first episode of Rebuilding Healthcare, and the title of this one is Breaking the Stranglehold of Health Insurance Companies. And the purpose of these roundtable discussions is to come together as a community of people who are in healthcare, who are working on solutions, and really come together and crowdsource good ideas that can help the American people and just help America in general fix healthcare. And it's an audacious task, but I think we have a lot of smart people here today to jumpstart this initiative. And I'll just go ahead and start off and kind of give a bio on myself and who I'm with, and then we can just kind of go around the room. So first of all, my name is Brennen Hodge. I'm founder and CEO of Citizen Health, and we are a public benefit company that's rebuilding healthcare from the ground up, just rethinking it, building some solutions to really lay out the infrastructure on some of the plans that we see coming in the pipeline. Other than that, that's me. I won't get too far into that. So, David, if you'd like to start your bio, then we can just kind of go around.
I'd be happy to. My name is David Balad. I'm the director for the Right on Healthcare Initiative with Texas Public Policy Foundation. It's the largest think tank outside of DC. And we're working with at both the state and federal level to work with lawmakers to fix our healthcare system. My background is that I've been a hospital administrator. Don't hold that against me, guys. I did that for 20 years. I spent most of my time doing turnarounds of hospitals throughout Texas and southern Louisiana. And what was interesting is people would say, well, how are you going to do this? Well, you partner with doctors. Early on in my career as a young administrator, I had a physician come to me and he said, David, always remember this. And I did. He said, nothing happens in a hospital except for at the tip of a doctor's pen. And when you have those partnerships, that's when we saw things thrive. And that's why my rate of success was fairly high. Because I saw what was happening in DC as it relates to healthcare, really the rhetoric, and everybody talking about you're going to lose your healthcare, this is such and such about your healthcare. I recognized that they didn't know what they were talking about. Beware of any politician that says anything about healthcare, because they're not talking about healthcare. They're talking about health insurance. And that really prompted me to run for U.S. Congress in the last cycle. Thankfully, I lost in the primary, and I continued my campaign for healthcare reform and became the advisor for a couple of congressmen and a few state reps. And during that time, started the relationship with Texas Public Policy Foundation, and now I'm earlobes deep in working with government officials. And I tell you, it is a fascinating world, and but I'm enjoying it, and I love the daily fight. It's I think my experience has prepared me for what it is that I do today. In terms of my philosophy in healthcare, it's really quite simple. Healthcare is the relationship between the medical provider and the patient. The reason it has become more expensive and more inefficient is because there has been the interference of middlemen, whether that be the insurance company, the pharmaceutical company, the pharmacy benefit managers, government. They've created more distance between the doctor and the patient. And that's been the crux of all of our problems. So everything that I look at is to eliminate that interference and put them in the periphery instead of in the middle. So we're looking at many, many things, and I'm happy to talk about those. I think I'll defer to the next introduction and philosophy, but we can talk about specific actions that we're working on here later, or maybe in the Q&A time.
Thank you. Good deal. Well, Dr. Ernie, would you like to introduce yourself? And I will say that Dr. Ernie reached out to me. We kind of met on Twitter. It seems like we've all met on Twitter, if you really think about that. And I had this idea, so we're co-hosting this. So Ernie, I'm going to kind of turn it over to you, and you can talk about your intro there, and we can go from there.
Thanks, Brennan. Good morning, everybody, and thanks for putting this together. I've been reading and listening like we all have, and obviously we're all on this call because we're passionate about fixing healthcare and getting better care for our patients at a better price, and maybe making a few more bucks for ourselves. I kind of echo what David said. I'm a urologist in Las Vegas, been in private practice 25 years. And, I'm reading the Twitter, I read other stuff, we read the news, and basically everybody's saying the same thing. We have these advocacy groups that are all kind of fighting for the same cause. I've been active in our urologic organizations. We have the academic side, and we also have a clinical side, and I'm the state representative for the American Association of Clinical Urologists for about 8-9 years from Nevada, and I go to the meetings, and basically the same thing, the same fight. We have our PACs like other specialties. And I thought, well, if we're all saying the same thing, how do we take it to the next level? So, I thought, well, maybe we should just get together and start somewhere and decide where we can go from there. What's the next step? How can we get to that next level? And that's basically, that's my story, and I'm sticking to it.
I like it. All right, who's next? My order on this screen's messed up. I just shrunk it all.
I'll go next if you want.
All right.
My name is Dr. Daliah Wachs. I apologize for the way I look today, but I'm a board certified family medicine, and I actually met Ernie about 20 some years ago, even though we're both not a day over 30. I don't know how that happened, but we met years ago. And I'm also a syndicated radio host. I have a show on iHeart and GCN Network, and I got very involved in advocacy and speaking out on things not right with our healthcare system. When I went on air, I was supposed to just kind of do a show where I answer people's questions about prostate sizes and cholesterol and diabetes numbers. And my first day on air, people wanted to know about President Obama's, healthcare plan and what a public option would do. And so since 2009, I've been pretty vocal, and luckily I've had a medium in which I could, vocalize. And so, where I stand is I don't think socialized medicine is the way to go. I don't think what we currently have is the way to go. And I'm very upset that non-doctors, non-pharmacists, dentists, and physical therapists, and nurses, and anybody else in the healthcare profession aren't the ones at the table when it comes to deciding what's going on with healthcare. It seems to be everybody else, including politicians. So that's where I stand.
I love it. Dr. Corba.
Hi.
Hey.
My turn?
You'd like to go next? Yeah.
Okay, sure. So I think I'm the only direct primary care doc on this call. I'm not sure. I think you all are pretty much aware of what DPC is, but for the general public who may be viewing this on YouTube or any healthcare professionals who aren't sure what direct primary care is, it's a growing, exploding model of primary care. Specialists are doing it as well, and a direct care model. And it's a membership-based model, kind of like Netflix. Josh Umber likes to, and Lee Gross like to compare it to Netflix. And what we've done is we've slashed the cost of primary care to the point where it's just a few dollars a day to for our patients to have unlimited access to us through appointments, after hours telemedicine, email, text, video conferencing. We give them same day, next day appointments for acute issues. Our appointments range from 30 minutes to an hour or more, depending on how many issues the patients want to discuss. There's no co-pays, no co-insurance, deductibles. 44 states can dispense meds in-house, so the majority of us who can do it are dispensing meds at near wholesale costs. All the prices are transparent, so as an example, with the wholesale medications, we make it clear to them if we mark it up 10% to cover our labor, bottles, and labels. Everything is discussed and transparent up front as far as the costs go. I was just telling somebody yesterday, I'll sit in the office and price out other options with patients. We'll shop for prices, if they need a test. We have one hospital system actually close by St. Luke's that does a really fantastic job with their online pricing. They're probably the only hospital in the country right now doing that, doing it well. So basically what we've done is we've all opted out of insurances. We've opted out of all the major commercial insurances, Medicare, Medicaid. We can retain ordering, referring, prescribing status depending on the state with Medicare, Medicaid. patients, and we're operating without having to deal with insurance. We do have to do some pre-auth still for patients, and don't mind doing that because the amount of time we spend on administrative burden in the office is so much less than it was before, that those few pre-auths don't really make a huge dent in our time with the patient. So the three things we bring to our patients is access, affordability, and attention. Our panels are smaller, so we can provide this high level of care to our patients. It's growing. Everybody's paying attention to it. We have attention at the state level, at the federal level, and we just have to make sure we don't get unnecessarily regulated. So I know David, I think they're working hard on getting dispensing rights in Texas, and I'm keeping my fingers crossed for you guys. I talked to, I forget who I talked to. Oh, I talked to Jeremy Snavely. He said that I think you guys are hitting the road next week for that. But if all doctors could dispense in-house, that would be a huge bonus. There are practices growing in the states that can't dispense, which is amazing because that's such a value-added service for our patients. And even with the executive order on Thursday that was issued, slashing getting rid of the protection, the safe harbor for the kickbacks, our prices for some of the medications are unbelievable. So that's a huge part of it. But we're keeping people out of the ER, urgent care, hospital admissions. We're cutting down on readmissions. We're cutting down on consults with specialists, unneeded consults. Specialists love when we call them from the office and discuss a case rather than just knee-jerk referring them over, because their schedules are booked too if it's something we can handle over the phone. So all around, we're really disrupting healthcare from the primary care level, and it's starting to filter into the specialists as well.
I have a bunch of questions for you later on, for sure.
Sure.
All right, Dr. Dixon.
Alrighty, y'all. So my name is Brian Dixon. I'm a psychiatrist here in Fort Worth, Texas. I have a direct care psychiatry practice. I'm a little bit different than Dr. Corbeau's practice. So I don't do the membership model, but I do a fee-for-service based on time because it just works for mental health. It works better for mental health, I think. But the goal, one of my goals, is to share with people that we've been asking the wrong question for years. And so when I was an employed physician working at a hospital, working within the system, physicians didn't have any control, as we've talked about earlier. And autonomy is so important to your mindset. It's so important to your ability to feel like you're in control, that when I quit that system, I said, I need to build a new system for myself that works, that is transparent, that really restores the connection between me and my patient. So that's what I did. And so I've grown the practice from just me to now 5 psychiatrists, I think. I don't know. I try not to run the business on the day-to-day stuff, but at this point. But I spend my time doing webinars and doing speaking engagements because I believe that we need to ask the right question. So the question that we've been asking for years and years is, how do we get universal coverage? And since we all know that coverage doesn't equal care, I think the better question is to ask, how do we put money into people's pockets so that they can buy their care directly from their physician? So that you can either be in the DPC model, you can do the fee-for-service model, you could do a concierge model, you could do group model, you could do capitated model, you could do Medi-share, you can do whatever you want to. I'm a big believer in liberty and that people have the right to make whatever decisions that they want to, even if it's a bad decision. I say this jokingly, but it's also the truth. You have a constitutional right to make bad choices. But I shouldn't have to pay for your bad choices, and your neighbors shouldn't have to pay for your bad choices. So I created a whole kind of new paradigm that I've been pitching around for the last couple of years, which we'll talk about a little bit later. But the idea is essentially making sure that people have the money to buy their care so that then the government's not involved, health insurance companies aren't involved, nobody is involved in your care except for your physician. and the patient. And so, and wrote a book and have a whole 9 yards, which I'm sure we'll get to later on. So.
Sure. Well, thank you all for introducing yourselves. I know, Dalia, since you're under the weather, you want to go ahead and kind of just elaborate on your ideas around fixing healthcare.
Oh my gosh, thank you. Yeah, I'll try to be brief because that could, oh Lord have mercy. I mean, it's interesting what I've heard Dr. Dixon and everybody say. I mean, I think many of us who've been in practice, we've even asked ourselves, why don't we just have the patient pay us and let them deal with the insurance? You know, I no longer practice, and the ACA was a big part of it. I was tired of the high deductibles. I was tired of always being overflowed with patients, not enough access. And I was really tired of big money being involved with things that we as consumers, whether I'm a patient or a doctor, should have control over. Now, one thing in my neck of the woods in Las Vegas is, and I'm sure you're seeing it throughout the country, are all these like emergency rooms pop up, these freestanding emergency rooms. And they're beautiful buildings. And, you know, on the outset, you're like, oh, great, this is increasing access. But here's another example of where you're really not having, you know, doctors and patients and nurses make the decisions. You're having big money people make the decisions. And people are thinking, you know what, we'll open up an ER, right? There's a demand for ER service. Let's just open up ERs and make extra money. Well, the problem is consumers or patients are finding that it's not really an ER, okay? An ER is attached to a hospital. So if God forbid anything happens, you're then able to go to the hospital, you're able to stay in the hospital, be there longer than 24 hours. And so these freestanding ERs seem to be like a little bit of a roach trap, you know, in terms of you come in and they're able to make money, and are you actually getting the care that you need? Now, mind you, ER physicians are phenomenal, some of my favorite physicians, but I don't think consumers really understand what sort of care they're going to be able to get. They're not going to be able to get their appendix taken out. They're not going to be able to stay overnight. They're still going to possibly be transferred. And we're finding more and more people, you know, get bills and, you know, getting surprise bills from these. Like one gentleman in my neck of the woods, his kid had a nursemaid's elbow. So it got popped into place. Not really much else was done, not even vitals taken. And he had a couple $1,000 bill. And so, you know, again, I don't want to do away with these, you know, freestanding ERs, but it's kind of an example of how, you know, somebody needs to kind of consult us and ask us what we think we need. Another thing is hospitals are now being concerned because these freestanding emergency rooms are now taking away resources. They're taking away emergency room physicians. We don't have enough. We don't have enough ER docs and nurse practitioners and PAs. And so now they're going to be able to, they go to these, and then who's staffing the hospitals? And our hospitals do need to make money. So it's, I mean, that's just one small piece of the whole picture. But, you know, if I could, you know, run for office, I would say, let's kind of do away with, you know, these insurance companies and me paying an insurance company to talk down the price. Let's just do direct, you know, kind of like more direct primary care or direct care where, you know, you just pay the physician. If you have issues and, you know, you deal it with yourself with insurance, I think it's going to really help doctors. It's going to decrease burnout, which is a huge issue in medicine. Apparently the latest study is 1 in 7 are thinking of suicide. Now, luckily there's only 6 of us, but my guess is if we had a 7th person here, he'd be thinking about offing himself. And so that's scary to me, you know, because our patients deserve better and we as professionals deserve better.
Can I follow up on that a little?
Yeah.
So her points are phenomenal about the urgent care and the freestanding. I feel that they serve a purpose as well, and I'm not somebody to say, I'm not in a position to say they should go or they should stay because it's a capitalistic society and it's a free market. But what we're seeing on the DPC end is you know, you go in there and you're seeing a physician or a mid-level, mostly mid-levels, and I have worked with phenomenal nurse practitioners and PAs, don't get me wrong, but some of them, these urgent cares and freestanding places are getting staffed by new graduates, which is concerning to me. They don't have a lot of experience yet. So you go in there as a patient, you have to repeat your whole medical history. They have no idea who you are. They don't know anything about you. They're treating you and and sending you home. And I can honestly say that more than 50% of my patients, and I try to discourage them, I'd say, call me first. If they go to these urgent cares, I end up seeing them again anyway for something. The diagnosis was missed, there was wrong treatment rendered, they're not getting better. And that drives up the cost of care. Thankfully, in DPC, they don't have to pay to come in. But in a traditional model, they're going to be paying another copay and waiting another 45 minutes because the doctor is overwhelmed and behind in an insurance practice. And I'm not sure that they're saving money in the long run. I really don't. I think in time that will shake out. But right now, I don't think they're saving any money.
Well, and if
or providing better care. I'm sorry, David.
No, that's fine, and I agree, and I think that on the heels of what you both have just said, let's talk about it fits nicely with these standalone emergency rooms and the direct care model. In a healthy economy, what you need at the very first step is transparency. What we have in our current model, not talking about direct care, is a complete and utter lack of transparency. Why are there crazy charges in these standalone ERs? Why are there crazy charges in the hospital? Let me explain it to you. It's not pure greed. In a sense, it's a responsible way and the fiduciary duty on the part of those that are running the hospitals. And let me explain that. In a hospital, we have thousands of contracts. Within each contract, you have tens of thousands of CPT codes that you're negotiating rates with the insurer. In those contracts, it says you will be paid, you, the hospital, will be paid the lesser of the negotiated allowable rate or the charge. So in order to not leave any money on the table, you inflate or hyperinflate, I like to say, the charge well above the highest rate that you'll get on any CPT across any contract in your inventory. That's silliness. We never expect to get our charge. So it's not a transparent market. It's a game that's played in order to conduct business in the best way that you know how. The insurance companies have created artificial markets. We don't have a free market in healthcare. And I always laugh when people say, well, we need to go to a socialized model because the free market hasn't worked. The free market isn't being used. We don't have a market-based economy in healthcare at all. Direct care, people will say, well, that's just, it's a gimmick, it's a fad, it's not really something that will fix healthcare because it's such a limited subset. That's absolutely wrong. I really believe it'll have more of an impact than most people understand. It is providing the transparency and providing a direct charge. You know how much something will cost. And that's really going to be the key. Pricing in economics is like the nervous system of the body. It allows, there's going to be just lightning fast reaction based on the market of increases and decreases based on consumption. The models that we have today don't allow for that. And I'll say this, one other key, and I think it was Brian and Dalia had said this too. What we're looking to do in Texas, there is a waiver, surprisingly under the ACA, that it's a 1332 waiver. And one of the components of it is something that we're really excited about. We would love to see introduced in the state of Texas. It will allow for a health expense account. We try not to say health savings account because that is governed by the IRS or managed by the IRS. A health expense account would be specific to the state itself. And let's just use Medicaid, for example. Well, no, let's stick with the ACA. So the ACA has about $5 billion in subsidies. In Texas, we had about 1 million of the 8.8 or so that enrolled in this past year. Of the 1,900,000 received subsidies to the tune of about $5 billion. If we received that money here in Texas and we were to allocate based on a criteria that we thought was more fitting for the people of Texas, because healthcare is local, as we all know, then they could get that subsidy on a card and they could shop in the way that they best understood and was best for themselves and their families.
And they could shop price transparency then.
Absolutely. And the other thing that we would do in conjunction with that is offer a market with not just ACA plans, but with short-term health plans, association health plans, catastrophic only plans, direct primary care, direct care. More option and more choice is the freedom that we all want for ourselves and for our families. Again, it may be easier in smaller states, but Texas, for instance, and Brian can attest to this, the people and culture and geography of South Texas is very different from that of North Texas, and very different from that of West Texas and East Texas and Central Texas. Healthcare, again, as a hospital executive, my primary service area was 1 to 3 miles. That was my community. I don't understand how DC expects to take care of the needs of the people of this country without knowing really the people in those communities.
Yeah, I completely agree. It's one of those things, kind of the overarching philosophy, because we're going to always run into the people who say that healthcare is it a right versus a privilege? And rather than get into some of the nitty gritties of that philosophy, I always remind people that water is far more important than healthcare. And we as a society have figured out how to provide water to everybody, but you also pay for its use. So nobody dies of thirst, but you also don't have the right to fill up an Olympic-sized pool and not pay for it. So there are mechanisms, there are cultural, there are socio-political structures that we can put in place as communities, as states, which is what I advocate for, as a nation, where you can provide some basic stuff, as well as kind of blend that the markets, the social safety net and the capitalistic markets.
Yeah, Brian, I'm going to steal that analogy. I like that about water. It's fitting. So I think we're all in agreement that transparency is needed 100% of the way. Because I mean, just for instance, me personally, a couple of weeks ago, I was looking around for a ophthalmologist appointment. I got some eye problems, and I got 4 quotes, and it was difficult just to get a quote. And I'm paying out of pocket now. I'm practicing what I preach. It was from $142 to $364 in price just for one visit, and it was like just in a wide array. It's like 4 or 5 quotes I got, and I'm just thinking that's over a 200% increase from the lower to the higher. If I could have a marketplace where I can go and shop directly, I can search for a price range that I'm looking for. I can search for a particular physician that I would relate better to, male, female, age range, read the reviews, find somebody within a general location and select them based on my values and my price range. That's a free market, and being able to purchase it directly. And that is that's something that we need. And Dave, like you said, people say, oh, the free market's not working. No, we've never had it at all. So I think once we do introduce that, it works, and people will start to see that it works, and that will start to expand beyond primary care into specialty, and to really just to everything that you can, everything in healthcare.
We had a little bit of a free market. You're probably too young to remember. But when I was little, I was just talking to my dad about this last night. My family had major medical plans for me and my brother. My mom paid $20 or $25. We went to the pediatrician. That wasn't covered. I think there was partial coverage of immunizations. She would pay or write a check, and then the insurance company would reimburse her a percentage of the immunizations. But you better believe she kept us at home until we were like half dead before she took us to the pediatrician. And she tried to, get us better at home. And a lot of times we did. We didn't run to the pediatrician for every sniffle and sneeze. But she would be able to take us to wherever she wanted to go, because she had to pay for the visits. That major medical plan would cover ERs, hospitalizations, and specialists, from what my father told me. But if she didn't like the pediatrician I was going to, then she had the option to go somewhere else. And, if that was more, if it was $35 for a visit, then that's what she chose to do. But we're talking 45, 50 years ago. So I think that's such a distant memory. Most people don't even know that, that's kind of the way it used to be with the wraparound, the major medical policies that we all are hoping will start popping up.
Yeah, that's a good point. Insurance back then was true insurance.
Right.
And also risk, a potential risk that might happen. Now it's like there's this prepaid sickness funds, basically. You prepay for sickness care. And the insurance companies have really turned into a financial behemoth, investment banks. They act like mini investment banks. I mean, the main way they profit is by holding on to our money longer and longer. I mean, they're not out there just making money off, taking these premiums and I pay out these claims and I'm taking that float right there, that profit. And no, I mean, they're actually investing our money into stocks, bonds, real estate, various things. And you've read some things in the past where these insurance companies are actually investing in fast food companies, into tobacco companies. It's like, well, health insurance companies are investing in this. And I think once the public found out about that, they kind of pulled out of those investments. But the reality of it is that these insurance companies, they don't have the patient's or the physician's best interest in mind whatsoever. I mean, they're out there for profits. And understandably, that's fine. You profit, it's a free market or it's a capitalistic society. Yeah, that's great. You can profit. But when it gets to the point where we're at now, as that inflection point where it's just not sustainable anymore for these publicly traded companies to sustain profit after profit, quarter after quarter, because now the American people can't afford it. I mean,
Brennan, can I jump in there? And
Sure.
I think it's important to understand capitalism is not evil. Profit is not evil. What is happening with the insurance companies and the pharmacy benefit managers and the pharmaceutical companies is they are using those profits to then fund lobbyists to protect regulations that they have paid for that protects their market. It's anti-capitalistic. And they've created an oligopoly that protects their position. That is inappropriate.
Yes, completely agree. And Ernie, you got a slide on his deck he's about to present, and it shows basically all of our politicians who are funded, who have money donated to them by all your pharmaceutical companies.
Oh, I can't wait to see this.
It's called.
David just did my whole. David just did my whole talk.
Don't give it to Mary and Matt.
Sorry.
It'll go viral today.
David just did my whole talk in 2 seconds.
Well, let's hear it. Let's go ahead and hear your presentation, Dr. Ernie. You can
right.
share. You can share your screen. And
Thanks. I'm technically challenged, so please bear with me. All right. 1 second. What are you guys seeing, not seeing?
I'm not seeing anything yet.
So I'm basically sharing my screen here, right?
Yeah, there you go. It's sharing now.
Is that it?
There you go. Yeah.
Okay, can everybody see that?
Yeah.
Okay. So you know, this topic is break the stranglehold of healthcare insurance companies, which I abbreviated. That's my Twitter at the bottom. Let me see. I'm just trying how I can shrink my screen a little bit here. So basically, you know, we talked about capitalism. Do healthcare? Can everybody see that?
Yep.
Yeah, we can say fine.
So do healthcare insurance companies and hospitals, for that matter, really belong on Wall Street? As we know, executives, shareholders make exorbitant dollars while patients and doctors are used, abused, and I've never used the word before, but even bamboozled. Should Congress vote on our healthcare while they may have stock or their family may have stock ownership in this company that they're trying to vote on, and or should they be taking money from this industry sector and also voting on our healthcare? While physicians must be fully transparent, hence the Sunshine Act. 2, you know, we all go to medical talks and the doctors have to make their disclosures with relationships with industry. And then C, you know, we're not allowed to talk to each other about how we practice and what we charge, the Sherman Act. So what bothers me the most is these networks. I mean, we're not cell phones. So, you know, what's going on out there? Is there collusion, which is, you know, an overused word these days, as we all know, resulting from excluding healthcare providers, whether they be doctors or hospital systems, that are not in the patient's network? Maybe these out-of-network providers, whether they're local or far, may be better able to deliver a better and more cost-effective care. Patients should be able to seek care with any provider and at any facility they're choosing, whether it's nearby or far, without their out-of-pocket expenses basically doubling. I mean, when you look, we all have the same crappy health insurance. Well, most of us do. And if you look at your plan, your co-pays, your co-insurance percentages, deductibles seem to double if you see an out-of-network provider. We can buy food and shop for clothing anywhere we want, so why the difference with healthcare? Is this restraint of trade? That brings me to the Mccarran Ferguson Act from 1945, which is basically bothers me because I think that may be the root of this anti-competitive behavior. And this was in 1945, and it had to do with interstate commerce. And I'm not a lawyer and I'm not a politician, but basically it went back and forth with interstate commerce and whether or not it should fall under the same, healthcare should fall under the same rules for interstate commerce. And one thing led to another, but the essence of this act is that it partially exempts healthcare insurance companies from federal antitrust laws. And the main advantage to these companies to have this act put in was to share loss data so they can, make rates and what have you. But it really allows them to sit down and they're allowed to talk with each other. And it's no surprise that when you look at some of the plans, they all pretty much have the premiums are almost near each other. They're almost identical with the same out-of-pocket deductibles. You look at one looks like the other. What it does, though, it allows the states to regulate insurance as opposed to the federal government. The House of Representatives bill, HR 372, which was, hold on.
Ooh, that's a good screen.
So, where am I? So HR 372, which was from Paul Gosar, who's a dentist in Arizona, and the American Dental Society has been all over this. If you Google the Mccarran Ferguson Act, according to what I read, this act, the repeal of this act actually passed the House in March 2017 by 416 to 7. I can't read part of my screen because pictures are on the right. And then apparently Steve Daines, a senator from Montana, brought it to the Senate, and it was introduced just more recently in December of 2018. And I don't know what happened with that. Maybe David knows more about that. And then in just doing further research and reading, there's this gentleman, I don't know how to pronounce his name, but he's basically the Assistant Attorney General, the Department of Justice, who's in charge of the Antitrust Division. And, he's got some mixed interests as far as whether it's, on the industry side or protecting consumers and providers. I got on this website the other year, this opensecrets.org, and if it's true, you can actually see how much money is going to Congress, whether it's money it's just lobbying efforts or political donations or what have you. You can break it down by whatever you want and kind of drill down on who's getting what and from who. And actually, which the big, obviously the big providers, the Aetnas, Humanas, whatever, are obviously the leading contributors. So you can go on this and see what's going on in your state with your representative, what have you. And it's very interesting. The real question is, what are they buying? We know what they're buying, as David alluded to earlier. Well, what can we do? The reason I reached out to Brennan, and it's gnawing at most all of us, I guess, is when is the rubber going to meet the road? Do we do it? Do we reach out to our state medical societies and go state to state, which we can do? We all know people. Do we go to our medical specialty societies and their PACs? Most of the specialty societies have their PACs, and I think they're all kind of doing the same thing. They go to Congress, they meet with them, give them a few bucks. And I don't think, it certainly helps to build relationships, but obviously their money is no match for what industry can give to them. There's social media, there's the social media docs, the Twitter people, there's the press that we can use. There's physician outreach like we're doing today, peer-to-peer. Should we consolidate the multiple physician-patient advocacy groups? I was telling Brennan when we first met a few weeks ago, And it's great. I mean, there's patients for this, doctors for patients, patients for doctors for patients. You know, there's multiple groups out there, and I'm not bemoaning, but we're all trying to do the same thing. Can we consolidate our efforts? And most importantly, which I'll just to do a little sidebar story in a second, but our patients, they're the voting public. They vote for these representatives. Can we recruit and assist them in going after their local members of Congress, sending the same message, saying, why are you taking money from company X and I can't afford to see my doctor? Can we hand out one-page sheets to our patients and help them get out to the people that they elect? Because Democrat, Republican, whatever, everybody's got their hand out. So, but I think the patients are, I think that may be where, we can recruit a lot of help. I just tell a story. I because of the medical malpractice crisis, this is a little sidebar, back in 05, 06, when St. Paul pulled out of the malpractice insurance market, my practice, as you know, went through the roof. And my malpractice as a urologist in Vegas went from $32,000 to $72,000 overnight. So I got upset. I went on the internet till about 3, 4 in the morning. And I ended up co-founding a self-insure, as a risk retention group or captive, just for my specialty, urology. And we insure several hundred doctors just in urology, and we've been doing that 10 years, and it's really been a lot of fun. It's my little hobby and passion on the side. But the point of my story is, one of our largest groups, the largest urology group in New York City, the head of their group was very politically active and still is, and was trying to get in to see a politician, and he could not get through the front door, wouldn't take his calls. And then he realized that a lot of his patients, most of his patients, were in this politician's district. So he used that as leverage, and he said, hi, this is Dr. So-and-so calling, and by the way, I have, X number of patients, and they happen to be in your district. And next thing you know, the door opened, and they rolled out the red carpet. So I think, again, I think we can use our patients because we want to help them, and they can help us. Just as an example of how, when doctors come together, back in California, when malpractice again, there was a crisis back in the 70s, in 1975, and basically what brought this out was that the decade prior to 1975, the number of malpractice claims basically doubled, and the awards basically went up tenfold for the decade prior to 1975. And I'll just read this and then I'll make some comments. MICRA would not have come about in California or certainly not have come about as quickly as it did during the summer of 1975. I'm losing my screen here. Sorry about that. Anyway, I can't read the right part of my slide, but basically they told the physicians in Southern California that they were not going to renew them, and they told the physicians in Northern California that their malpractice was going to go up by some astronomical figure, and the doctors ended up striking, and they went to Sacramento and they protested, and the long and short of it is that's how the MICRA Act came about, which basically put a cap on non-economic damages of $250,000. So the point of this slide is that when physicians come together, they can get things done. Should we, format together as a group and have these societies come together and put together a sample letter to our elected officials? We talked about before, we all want freedom of choice. We talked about health savings accounts or other type of accounts that are done in Texas that David talked about earlier. I think personally that if we can abolish Mccarran Ferguson, it may allow for competition and not afford these insurance companies the antitrust exemption that they're getting. We talked about ERs, freestanding urgent cares, transparency, so patients don't end up going to a facility that's not in their so-called network. Disclosure, financial conflicts. Dr. Corba talked earlier about direct primary care, which I'm learning more and more about. And then at the bottom there, we talked about the patients and getting them involved, and basically saying, remember, I'm one of your constituents and I will be voting in the next election. Well, I just pulled up just doing a Google search how you can contact your congressperson. And I'm sure there's multiple vehicles like this. Usually, if you're lucky, you get to their healthcare advisor, the person that handles that within their office. But again, we're trying to reach into Congress and get their attention. But if we're sending a unified message, it may help. And that's about it. That's about all I have to say this morning.
Can I ask you what happened to that bill? I was looking it up while you were talking. The House bill for that it passed the House in 2017. Hold on, I have it here. HR 372, the Competitive Health Insurance Reform Act, 2017. Can you go back to the slide that showed the Senate bill?
Second, I'm sorry.
I didn't write it down fast enough. Actually, I don't even have a pen. Hold on.
Can you see that?
Yeah. So it passed. Yeah, it passed. And then is the Senate bill the Senate companion bill to that, to 372?
I believe so.
I wonder what happened to it. I'm gonna look that up. I haven't seen anybody talk about this yet. Have any of you guys?
Well, Mccarran Ferguson I agree. It's been an issue, and it allows them to circumvent the law, which is what I was talking about earlier. But the fact that it did not go through in the Senate would mean that it would need to be introduced again in the new Congress in both the House and the Senate.
It might be prime for the picking now, though.
With the kinds of votes that it won by in the House, there shouldn't be a reason why it couldn't. Because one thing that I did hear when I was up in DC was that if you have 190 co-sponsors, it doesn't go through committee, it goes right to the floor. So if there can be 190 co-sponsors, and if obviously there have been Democrats that voted for it in the past, then this should be something that could be done on a bipartisan basis.
Yeah, I'm looking at the Senate bill right now. It went to committee. It was read twice and referred to the Committee of the Judiciary just in December 19th of 18. Mm-hmm. So it just sat there, I guess, before that congressional term ended.
They weren't going to do much in that period.
No, but I haven't heard this one brought up very much. This issue, this anti-competitive issue. Thank you for bringing this to our attention.
Sure. I mean, I think I don't know where I picked up on this, but I've been going to meetings forever, and basically I interpret this as it just allows them to. This is why I think everything looks the same, and we talked earlier, or the politicians talked about opening up so we have more competition and you can take your insurance across state lines. I think it's ridiculous. Even these Medicaid programs, there's so much waste. I live in Vegas, but I practice in Northwest Arizona, about an hour and a half outside of here, and it's a rural area. And I'll just share one case with you. I saw a kidney stone patient years ago who is she's in Southwest Utah. And she ended up going to an emergency room in Utah. She had Arizona Medicaid, and they didn't want to deal with her. She went to a rural hospital in the corner of Nevada, and they didn't want to deal with her. And then she ended up on my lap. So it's amazing that I think maybe it was Dr. Corba talked about earlier, that if she fields the calls and takes care of her patients, she can head a lot of things off at the pass and save them time and money. And this is just going on and on and on. And because of the networks and the insurances and not crossing state lines and all the nuances, we're adding to the healthcare costs. They wonder why our healthcare costs are, $3 trillion a year or something, or that's how much we pay. And we got maybe $2 trillion of value out of it. I think Brennan said something like that when I talked to him a few weeks ago. But sometimes the patients are just going from hospital to hospital, to doctor, and there's just so much waste. And if they got to the right person, or if their Arizona Medicaid would be accepted and honored by that Utah urologist who could have taken care of their stone, there would have been so much savings. I don't need to explain to this audience. So there's just a lot of waste because of the networks, because of the restrictions, and maybe breaking this stranglehold here may open things up.
Yeah, I would throw out there, and Ernie, thank you for that presentation. I would throw out there that in trying to solve the issue, me personally, I would skip Congress. I don't. The best way I describe it, and I tell my patients this all the time, is you don't go to Pizza Hut and demand a hamburger, because if you go to Pizza Hut and demand a hamburger, they're going to look at you like we don't serve hamburgers, and so. When it comes to Congress, they have their own vested interest in mind. They have their own agenda. They have their own focus. And I can appreciate the democratic process. I can appreciate us, writing letters. The most important part, of course, being voting. But I would much rather spend my time and energy and effort and encourage other doctors to, number one, you have to start your own practice. Until you can control how you make money, you will forever be beholden to somebody else. That's just, whether you're employed with a hospital, whether you're a professor at a university, whether you are, working retail at Lululemon, unless you are in charge of your company, somebody's always going to be able to tell you what to do. And physicians need to be able to own their livelihood. Unfortunately, and this is where I think a lot of the everybody has sinned in creating this cluster that we're in. Doctors gave up a lot of their own autonomy and let other people run the business of medicine, insurance companies, pharmaceutical companies, the government, so on and so forth. But I think that we need to, I think current physicians need to own their practices, and then we need to teach the up and coming physicians how to start a business, run a business, be that DPC or another model. But I just do not see, and again, I know that we can multitask and we can do a lot with letter writing, but they're just not interested. And we could wait on them to come to their senses, but their goal is different. And I don't see them ever saying, yes, doctors, let's help you. That's not going to happen. So I would be much more inclined to say, let's just start our business. Let's teach other doctors how to do business. And then for those doctors who are terrible business people, they can be employed by businesses that are owned by doctors, is what I would say.
Brian, I would say yes. And I think, yes, absolutely, physicians need to break out and opt out. But I do believe that physicians need to make their voices heard. You look at what's the recent success, Physicians Against Drug Shortages, PBAs Involvement, AAPS. There have been about a dozen different organizations, thousands of doctors that have just advocated for lower drug prices and have really come hard against the pharmacy benefit managers. Well, look at what they've done. They've worked for years, and they've been persistent and relentless, and that's what they need. And we've seen some action on the part of the administration, which is good. Whatever we think about the administration, here they've done something that has been beneficial for both physicians and for patients. Now, I'll say this to you too, and it was a shock to me. I visited CMS when I was in DC, and they said, well, we deal with the AMA. My personal opinion, and I don't speak for a large group of people, I don't speak for all physicians, but the AMA, in my estimation, doesn't really represent physicians. They represent the AMA, but they have such a membership that's who the government listens to, because they say they have 30,000 members, and they are the physician representation in this country. And I said, look, what if we were to come to a table with an umbrella organization that had all these other organizations and their representative membership under it, and it was to the tune of about 20,000 people? Would that be meaningful to you all? They said, you'd have a seat at the table. So that's what we're working on right now. And please feel free to share my information, Brennan. We're going to try to create this coalition, and we're going to have the physicians' voices be heard. I'm a facilitator. The physicians will be front and center. It's their voices that are important. This is their message. And as Brian has said, they were complicit in this problem because they weren't able to come together, and they really didn't make their voices heard because they were focused on their patients. They were focused on their calling. But in order for that to continue, for that to really progress and to have the kinds of things that we want to do that are good for this country, we have to be involved with.
Can I follow up on that? I agree with all of the above, and I say this to a lot of people. This is the only healthcare, the delivery of the care of health by a physician to a patient is one of the only industries where we don't dictate what we charge or what we are involved in how we're paid. I don't want to, I'm not demeaning healthcare, but, any other trade organization, if my plumber charged too much for my toilet repair, I'd find another plumber. Or if the results weren't good and my toilet didn't work after I paid a lot, I'd find another plumber. So we're performing a service, and no other industry is in the pickle we're in. And you're right, we were all complicit in letting this happen. I don't think it's too late. It's never too late, because there's nobody else out there that can replace what we do. You can try and flood the system with mid-levels, but nobody will ever replace the physician. So we can fix this, and all of the things that were mentioned are steps in the right direction. But I do think making our voice louder and coming together on all of the advocacy issues is going to be needed.
I'm going to add to that.
Mm-hmm.
I completely agree with that. We have to make our voices heard, but at the same time, I don't think that's enough. Just because we're saying we want this and this, Congress, they'll listen to us, but at the same time, we're not necessarily giving them money. We're not donating to their campaigns. We're not lobbyists. What I would like to see is these physicians coming together. We have to come together. We have to have this unified voice. We have to be strong about it. But then not just make our thoughts heard, but also present a plan and say, look, we've come together. We're the group of people who actually do practice healthcare. We make this go around in this country. This is what we propose. And not just saying we would like to see this change, but actually put together a 100-page document and turn it in and say, this is what we want to see done. Like, we've already done the legwork. We've talked to everybody. This is what the people want. And I think that's something that would help more than just just a voice.
I have to agree with Brian. I think there's a limited amount of we can get done, and what David mentioned, what Pads got done was amazing this week, but it took a lot of blood, sweat, and tears and a lot of time. I agree with Brian. I think the first thing that doctors need to do is break free of the chains and just worry about taking care of their patients the best way they know how. I think working at the state level is also very important. We haven't really talked about that. Our states our states function independently of each other. They all have their own agendas. Everyone's different, and then you fall under the federal guidelines. But I think what's happening at state levels is also very important to focus on. And I'm not sure if it's more difficult or easier to work at some state levels. I can say my state is probably more difficult than working with the federal government. But Texas is making huge strides. You guys are awesome down there, and everything. It's just should probably still be its own country. But so I think we need to also focus more on the smaller scale. The federal is important, but it does. We have a proactive administration, regardless of what you think of Donald Trump. He's making strides, and the administration's making strides to try and fix this. And they are under a time gun. He's got a little limited amount of time to get done what he promised. So, but I don't think we should forget about the state level, and physicians also need to just focus on what they're doing individually, because if we all make a small difference collectively, that is a large difference.
Yeah, and I would throw in there. So one of my favorite quotes is by Will Rogers, and he says that everybody can't be heroes because somebody has to stand on the curb and clap as they go by. And physicians, and this is kind of the elephant in the room, physicians are not very good at organizing, and I don't think it's a moral failing. I think it's partly because we are literally trained to be the heads of a team. And I'm a big fan of Star Trek and the whole Enterprise. And one of the funny parts about Star Trek is they had an episode where they had all the captains on the bridge, and they're like, well, who's in charge? Well, you can only have one captain of a ship. And so, and then everybody else has to learn how to follow, and we're not very good at following.
No.
So Kim, you bring up a great point. When it comes to creating the infrastructure to lobby effectively, we have to, I'm not going to do it because I'm not a lobbying person. That's not my personality. But you have to put money into it. And then you have to trust the message, and you have to trust the marketing, and you have to, it is an enterprise all by itself. And so until doctors learn to stand on the curb and clap, we're just not going to make as much headway. So I agree with you. I say taking it to the individual level where you work with your patients, you hone your message, you take care of your babies, your families, and then you take it to the state level and do your best to strong arm your state level officials into doing what's right. I think that's probably more effective than trying to lobby the federal side, who half the time can't get their act together.
I'd like to weigh in to what Brian's been saying. You know, if you're primary care or you're a psychiatrist, I think it's a little easier, especially now with direct, I don't know, again, I'm not an expert on direct primary care, but I know there's a lot of the concierge VIP medicine throughout the country. There's direct primary care, there's psychiatry. I think it's a little easier to do that on certain specialties. And taking care of your own business, you know, is great. But I think the bigger picture is the access for us, even as patients and our families and the patients that we see every day who, you know, half of which are miserable, and they complain to you that they can't afford their medications, they can't afford this. You know, as a surgeon, they cancel their surgery the day before because they can't pay the hospital because they have a high deductible. I mean, the whole system is very wasteful and very disruptive. So I'm speaking more for the patients, me as an insured person, and my family and the patients that I take care of. The system really, I think we need to do more. We need to go to the state. We have specialty societies. And I think if we take the same message, a common theme for intellectual resources, because, you know, we all pretty much have the same, you know, similar messages, and pool them and get a common thread, like Brennan was saying earlier, and just kind of ram it down their throats. I mean, I think the gloves need to come off. And again, not getting into politics, but, you know, when Trump's talking about the wall and it being a national emergency, our healthcare delivery right now, I think, is in a national emergency status. You got patients in medical bankruptcy. You got people that can't afford to go see their doctors. On and on and on. So I think we need to take it to that next level and decide where we're going to go with this. Otherwise, we'll still be saying the same thing 5-10 years from now.
I agree, and I think the way patients can make a difference, and it's not always an option, is to vote with their wallet or to make a difference with their wallets. You know, the health sharing ministries aren't for everybody. They're health sharing plans that are not religious based, but they are a little scary when you look at them. You know, looking for alternatives, and there are some places there aren't a lot of alternatives, but and I don't know if it's happening fast enough. I think if patients had more choices, they would make choices with their wallets faster, and that would really drive a stake into the current system. You know, they extended the short-term limited duration plans, the association health plans for the employers. There's steps being taken, but not all the states are allowing those expansions. So that's hurting the people within those states because it's limiting their choices. My state, I would love to have, you know, a short-term limited duration plan for my son, or I would love to join an association health plan with 4 other states for DPC doctors who own small businesses, or healthcare professionals who are independent, but my state won't allow it. So I think a big part of this too is, and it's scary for the patients. Like I said, they are accustomed to their insurance policies, even though it's beating them over the head with costs and restrictions. I think that's the public, as far as getting their involvement, like you had mentioned about getting patients to write letters, helping them make healthcare choices with the dollars they spend is also very important. That takes time to educate them about this stuff.
Yeah, people think, the insurance companies have a big brand. It's trusted. It's not, people forget the fact that they're denied on a regular basis by them. But, and I'm going to disagree with you, Ernie. You said earlier that we all have terrible insurance. I don't have insurance. I have great coverage. I have a direct primary care doctor. And let me give you the numbers. When I had insurance, my premiums for all 4 members of my family was about $1,800 a month. Today, I pay $200 a month for all 4 of us to a direct primary care doctor. I have 24/7 unlimited access to a physician if I need it. In addition to that, I have medical cost sharing, sharing ministry with a $1,500 deductible, and I pay $350 a month for that for all 4 of us. So I pay $550 a month, a third roughly of what I used to pay, and I have better coverage. So I'm thrilled with what I have. And I wish more people were like me in having that kind of option and choice.
Well, yeah, I mean, that'd be great. I would love to have something like that too. And but the average Joe out there is, they have limited choices. And but you're in the business, you understand it. You have that opportunity. I would love to have something like that, because really, why do we have insurance? The only reason we have insurance is, God forbid, if we get some bad cancer or get hit by a truck. We don't want to be bankrupt. We don't want to lose our house. But the day in and day out care, I would love to have something offered or something available, like a plan that you have. And I think most of us would.
Yeah.
I think that's where that's part of this whole conversation, this town hall is, what we do something better, cheaper, and make it reasonable. So it's real care. It's real health care.
Right.
I agree with you.
If you look at what insurance is, the technical definition is the transfer of risk. If I have a $1,500 premium and I have a $6,000, $7,000, $8,000 deductible, and then it's a 70-30 plan, if something bad were to happen, you're looking at $25,000, $30,000 out of your own pocket before insurance even comes into play. How much risk have you transferred?
Not much.
Not much.
Right.
Well, yeah, this is why we're having this webinar, because we want something better. This current delivery system it's not working.
Well, and that's where I would jump in. And so, Ernie, because I've heard that term, so healthcare delivery, and I always take a little bit of issue with it, and I write about it in my book, that we don't have a delivery issue, because when you get the right patient in front of the right doctor, they're going to be taken care of. It's just because that's what we do as physicians. We have a healthcare finance issue. So at the core, the way that we finance healthcare is really stupid, because we're giving money to insurance companies to insure against something that has a 100% chance of happening. You will get sick sometime in your life. It is just going to happen. So instead of trying to insure against it, why not just basically save for it? And so in my wacky idea that I put in my book and on my website is essentially, everybody understands the Costco concept. So literally every person you talk to, or Sam's Club, everybody understands the concept that you pay a fee, and once you pay that fee, you get special privileges by being part of that club. And so when I created the concept, I thought, well, why don't we do this basically on a statewide level? So you buy in, you pay your membership fee into the company, the state-based health Costco. And what that private company can then do is buy their medicines at cost. They can, you can leverage more of the economies of scale stuff, so that your prices of your medicines can come down. But then that's all it does. When it comes to the delivery of care, then you just pay out of pocket with the care for your care. And then for those people who have conditions unrelated to lifestyle choices. So there are people who are born with cystic fibrosis. You get type 1 diabetes. You didn't cause those things. There should be a mechanism or a savings account to help subsidize that care. And so as long as you pay your fee, you get that economic benefit, so that then that doesn't bankrupt you. And then for the people who can't pay their fee, or the people who can't afford to pay out of pocket for some of their other expenses, this is the part that's going to get me shot and killed. And so I tell y'all now, so that then I don't, if I come up missing, y'all know. Which is, we eliminate the tax exemption for hospitals and tax exemption for churches. And for every dollar that a church or a hospital covers on behalf of somebody else, their healthcare, that's where they get they can write that part off. So that then we are not paying we're not paying for care outside of the general bank account from the health Costco. So let's let churches and hospitals pick up what they need to pick up without disrupting physicians, so that physicians can post their fees, see who they want to see, work with who they want to work with, patients can work with who they want to work with, and we have a truly kind of free market approach to that side of things. So it's a wild idea, and I recognize that there's lots of details to work out, but the key is my goal again is to try to push this conversation out into the general public, because otherwise we're just sitting around talking about the same thing again and again and again forever. So I welcome thoughts, feedback. We don't necessarily even have to talk about it, but that's kind of what I'm working on right now.
You know, I'm gonna jump in there and add to that.
Though, Brennan, if I could say this.
Yeah, go ahead.
Sorry to interrupt. I think it's important. We're going to talk about this forever. We have the next 5 to 10 years to discuss it. Guys, we don't have that much time. Thing on who gets into office in the next election, or how the elections go in subsequent years, we may end up with a Medicare for all. So what we need to do, well, whatever it is that we need to do today and every day. This is not going to continue indefinitely. So I would encourage everybody, be motivated, be activated, be engaged today.
Yeah, it's like that proverb: the best time to plant a tree was 20 years ago. Second best time is today. And something kind of wraps up everything we're talking about is getting people together, getting physicians together, patients together, everybody to kind of unify a voice and really to try to bring on change. But this is something I want to present, something I've been kind of bouncing the idea around a few people. But make this a social endeavor. Like, let's make this a public, transparent movement to fix healthcare. Get 10,000 patients involved, get 10,000 physicians involved, get 10,000 nurses involved. Set a goal, make this a public event where we're going to bring all the best ideas to the table, and we're going to hash through it for the rest of this year, and we're going to present a plan that works with everybody involved. And make it, like I said, a public event. Try to pitch this to different news outlets, really publicize the heck out of this, and let people know that this is a serious thing. And you see people rioting in the streets for trying to Medicare for all, or trying to take different coverages away. People are emotional, and when people are emotional, they can get behind something if it means something to them. Healthcare it's dire to everybody. Like you said, Brian, it's 100% chance that we're going to have a problem in the future. So if we can rally the emotions behind all this and bring everybody together on one solid platform and have that one voice, I mean, that's where the power is. And that's how we can really make some change. If we do make this, it has to be transparent. It has to be open source. And I love the idea of being open, where everybody can see the motives for everything we're pushing forward, and everybody can make their own judgment calls. I'm actually giving a TED Talk in 2 weeks about open sourcing in healthcare. And this is going to be the topic of that. It's going to be open, transparent for everybody to be involved in, have polls, have different scenarios where people can put their input, and really craft a plan with all the parties that are actually involved in healthcare. It's something that's never been done before. And I don't like relying on 537 elected officials making the laws for 329 million Americans. That's going to affect healthcare. So why don't we flip that? Why don't we crowdsource a brand new initiative with the best plans and then present that? And whatever that comes out to be, whoever is the president, whoever is going to be running, it's almost like a public outcry saying, if you don't run on this public plan, we are not going to vote for you. Or likewise, if you do run on this or you do present this healthcare plan, then yes, you have our vote. Something along those lines. Like Ernie, you said, we got to take off the gloves. We got to throw some punches. And it's gonna take something that audacious to really make a change, such as fixing healthcare.
I completely agree. I'd say at the end of the day, and this is where the conversation about physician extenders comes in, because NPs and PAs are delightful people. Nobody's doubting that. I think one of the things that has happened is that physicians have used those positions in ways that are now kind of catching up with us. And at the very core of the issue now is that physicians have a marketing problem. People don't understand what we do. We understand what we do. So physicians understand why we've done what we've done. We understand the work that we put in. We understand the importance of expertise, but we're doing a really bad job at letting people know why they need to choose a physician. And as a result, there's this kind of vitriol and this blowback that anytime a physician mentions, hey, I need a higher reimbursement to keep my doors open, people get very, very, very upset. Like I've run into folks when I mention Medicare for All, I say, y'all, I vote Democratic. I'm a black dude from Texas. I mean, I grew up on food stamps. I understand the importance of social safety net. But at the end of the day, Medicare for All is a terrible idea. And people go, who do you think you are? You're some rich doctor. I'm like, dude, no, I live in the hood in a house that's less than $150,000. So, well, you don't care about your patients. No, I do, because I work Saturdays, which is I go to work right after this webinar. Well, doctors are just terrible. You don't understand. And I'm like, no, again, they don't know me personally. They're attacking us as a profession. Well, where did we go so wrong that so many people fundamentally misunderstand what we do? And I think that, I blame a lot on the insurance companies and pharma, but then I blame us because we are not doing a good job of marketing what we do and letting people know what we do. And so in the coming fight, not only do we need to try to organize, which is a daunting task in and of itself, but we also have to reassure our patients that we're not these bad people. But to me, that requires a level of cooperation that I don't know we can get. And so instead, I do what I can, but me personally, that's where I work really, really hard to do my one-to-one marketing with my community and with the people that I'm working with. But we need to have that conversation as well.
Yeah, if you believe in a capitalist market, a market-based approach, I can't tell you how many times I've been accused of being some big, rich, big wig. I wish they were right. It's just it's just not the case. I just believe in freedom.
Yeah, at the end of the day, doesn't matter how much money you have in your pocket if you don't have freedom.
That's
doesn't
right.
matter.
Exactly right. Our freedom and our liberty is essential. I'm a child of immigrants, and they labored and came to this country, and for people that say that income mobility is not something that exists, you look at what Brian's been able to accomplish. I see what my parents. I had a front row seat to the American dream. We're slowly killing that, and Medicare for All will be a huge nail in that coffin.
Yep. Gentlemen and everybody else listening, I have to exit. We're on our way to a lacrosse game at Lehigh University. So do you mind if I step out?
No, I appreciate your time today, and good luck with the game.
You had a question for me, Brennan. You said
I have a lot of questions about direct primary care and just kind of your experience with that. But we can talk off this.
Okay. Or if you want to do another one, we can save it for then, or you let me know how you want to handle that, because I'd love to answer your.
Yeah, I would like to do this once a month. I think we can start getting different themes. I do think DPC needs to be one central theme.
Okay.
The direct care. So we can start talking through that probably the same time every month.
I do want to say one thing. I think DPC is opening the doors for other direct pay alternatives. Direct primary care is one solution. It's not the only solution. And what Brian does with his psychiatry patients, that's beautiful and brilliant. Those patients, I consider psychiatry a form of primary care. It's a specialty. I'm not going to take that away, but it's primary care. And, you know, do all the specialists perform some kind of primary care at a certain level? Yes. So, you know, I think DPC is very important and, you know, a piece of the solution, but I like to hear that other models are also looking at direct exchange of money and services with patients, you know, that's not just membership based, but maybe per visit, time based, you know, so I like hearing that all of these things are happening as well. We all do. Yeah.
Yeah, no, and thanks for being the pioneer.
Oh.
The primary care doctors, y'all are out there really taking all the blunt from these critics out there. And
yeah, we've gotten beat up a little bit.
Oh yeah, people don't understand it, but they think that you're trying to solve everything with direct primary.
No, just trying to make a difference in our small neck of the woods. You know, if you don't have good primary care, it's not the cost of everything is going to be higher. You know, those cardiologists don't want to deal with somebody's rash. You know, they go back to see your primary care doctor. That's what they all say. Go see your primary care doctor. Well, you know, we're trying to make a difference now, and it'll hopefully decrease costs overall. So.
It's the foundation we need to build solutions on top of.
Well, thank you for all your support and everybody spending some time this morning. And I'm sorry I have to leave a little early.
Yeah. Bye, Cam. It was good to see you.
Okay, nice seeing you guys. All right, have a good one. Bye.
Bye.
Bye-bye.
Yeah, we're sitting here talking about free markets and the ability to choose and purchase healthcare services directly. I want to throw out some stats, some research I did. This was back from 2015. But the amount that we pay as a collective, as a society for premiums or out-of-pockets, all the copays, and the taxes we pay for Medicaid and Medicare, adding all that up, it's $2.6 trillion. That's a lot of money. Put it in perspective, about $800 billion is spent on military globally for the United States. Well, I looked, it took me a little while, but I went down Healthcare Blue Book, MD Save, and a couple other transparency websites. And if we pay directly for every single service for every man, woman, and child from birth to death, it would have been about $900 billion. Now, it doesn't include pharmaceutical spending. So just round it up to $1 trillion if we paid directly. So we paid $2.6 trillion, but it really only cost $1 trillion. And sure, add a couple more 200 billion, 1.2 trillion. Still, the point is, what we're doing is not effective. This having these intermediaries, these financial intermediaries in the middle, they're not solving problems. They're causing more problems. I mean, as a financial company, whether you want to look at them as a financial product or a financial service, you know, we're paying them to provide a service, to pay for our healthcare services if they exceed a certain level of cost. But they're just not doing a good job at all. They're taking our dollar, and once it gets to the physician, that dollar is about 30%, has about 30% of its power left. You know, and if you look at it just from a strictly consumer perspective, you know, if we have, just for instance, your cell phone carrier, you know, if you're on Sprint and you don't have service in a particular area, or they keep, you know, jacking the price up on you, well, you're going to say, well, you know what, I want to change. This is not a good solution. I want to change somewhere else. And that's kind of the idea that, or the ideas that we need to present to the American people, is there's an alternative. And I think that's where we're at now, is people don't understand there's an alternative. I go out there and I talk about direct primary care, and people have never even heard the words. Okay, that's a problem. Like, if I have to explain them what it is, they've never even heard it. Well, then that whole construct, the mental construct, has to be formed, and that education piece, and you know, all of this stuff has to be done to inform, I'm guessing, probably about 320 million people out there of exactly what this new model is, and there's new alternatives. So I think that's one of the biggest barriers that we have talking about what we're doing now, is just letting people know there is an alternative.
And I would say that that's where that marketing arm comes in, because everybody knows, I'm trying to think of, have you had your break today? When you think of a slogan or a jingle, companies do a very good job of getting their marketing out and their messaging. They pay some millions of dollars and they get it done. we don't have that apparatus to get that message out. And that's something that to me is a very tangible thing that can come out of this conference as well as other webinars or other meetups, which is we need to agree on a marketing platform so that all these different groups can kind of be heard. I don't know how that's going to happen. But to piggyback on something that you said earlier, people value what they pay for. They pay for what they value. I don't think I've ever really met anybody who wants healthcare for free. I think that everybody wants to be able to pay something for it. It just needs to make sense. And so that statistic that you just mentioned about if everybody just paid directly and, it's like $900 billion as compared to 3.4 trillion, which is where we are now. I mean, that's amazing. And I'm really glad that you did that research because it does not have to be so terrible. It doesn't have to be, healthcare doesn't have to be this expensive, and it'd be great to have that message get out there. But again, I think it all comes down to marketing.
Yeah, it's a good point. I was just at a birthday party this past weekend. I was talking to my brother-in-law, and I don't talk about healthcare too much. My wife says you can't talk about this every single family event. So I just let everybody else do the talking, and he was telling me about he went to go get an X-ray, and of course he doesn't have insurance, and they through his company they said, yeah, we're going to have to bill your company's insurance or something, whatever. It was about, I think, $550 is how much they were going to bill his insurance for a simple X-ray for his hand, I think. And then they said, well, if you pay cash, it'd be 50% of that. And that was like a cash payment if they bill him. They said if you pay cash today, it's only going to be $100. So he's sitting here like, that math doesn't even add up. You're going to bill my company's insurance for $550 or something like that. And, simple things like that, once people realize that, whoa, like these prices are so inflated, they're so irrational that I could just pay cash directly right now and save that much money. And once people start to see that, then, the light bulb goes off. The education piece is there once they see that price. There's nothing else you got to say. Money talks.
Well, and it does make sense to a degree. The infrastructure a physician or a hospital needs to collect the money for the services that they render is up around 35%. If I had cash on the barrelhead, I'm making more money by charging less. If that makes any sense. And I wanted to address, I saw one question on the chat. Somebody had said that direct primary care is not affordable by the average employee. For many people, that's true. But when you look at what they're charging, it's anywhere from $50 on upwards to $100 a month. It's pretty affordable. And in fact, I was talking to a friend of mine, and some of you all may know her, Dr. Kat Lindley, and she's up near Fort Worth, near you, Brian. And I think she said that she's exchanged, so many eggs a week in exchange for primary care services. There's bartering going on. People talk about DPC as something that's new and revolutionary. I would argue that that's the way that healthcare started. People paid cash for a visit from the doctor.
Exactly.
Yep, and I would. It's really funny being a small business owner now. I didn't grow up in small business. My parents weren't business people, and so I think I think there's 5 doctors total, including me, plus 3 employees, and I can't afford to provide them health insurance because it's so expensive from the employer side of things. And so that's one of the reasons why. And so I just pay everybody extremely well, and then they get their care however they choose to. Some people are on their spouse's insurance. Myself, I just have a catastrophic plan, and then I pay for everything else out of pocket. And that motivates me to get up and work out and eat my steel cut oatmeal and get my sleep. And it works really well for me. But at the end of the day, everybody needs to be able to have the freedom to do what they think is best. And I totally believe that everybody can afford healthcare. And if you can't afford it, if for some reason it's just not possible, that's where I advocate for that tax exemption status. There's no reason why those two entities need to be tax exempt, in my opinion. And that is billions of dollars that can be used to provide the cost of care. The rate limiting step, of course, is that we need to bring the cost of care down by being transparent and letting doctors compete against doctors, letting doctors compete against in the states where NPs are practice without supervision, then we compete against them. That's what keeps the cost of care down, is when you have competition. And so I'm all about transparency, like you had mentioned earlier, Brennan. And I think that that's another avenue to really to create competition. For one last thing I'll throw out there, and again, these are all wacky ideas. I don't know that it would ever happen, but I would love to see, especially with hospitals, I would love to see us create a new designation called medical hospitality, where hotels can, or hotel chains can build hotels that are specifically for medical purposes, because there's quite a few times when you're in the hospital where you don't need to be in a room that costs $1,000 a day. You just need some place to hang out and have your doctor come to you and make rounds. And that, to me, would create competition for that medical hospitality space, or the hospitality space, or hospital space. And that would also drive down the cost of care. So, I mean, if we're truly going to change that paradigm, let's just go all out and see what happens. But again, I'm kind of a big dreamer, so who knows?
I'm gonna have to think on that a little bit. I like that idea a lot.
Me too. I will disagree though. With the nonprofit hospitals, I can go there. I don't know about the churches. You and I are gonna have to fight on that one.
Sounds good. Yeah, we can go toe to toe.
Right.
One thing that we're working on now, we've been kind of keeping this fairly quiet up until now, but we're basically building the Amazon for healthcare, for transparent prices. And everybody's probably familiar with MD Save, and I know the Free Market Medical Association coming out with their Shop Healthcare. And so there's a lot of other entities out there that are doing something like this, just really bringing transparency out in the open. But having physicians go out there and being able to actually figure out the prices is step one. What will I charge directly for my services? What is my time worth? And getting them out there to list out, this is what I can do, and this is what I want to charge, and have people be able to find that. I mean, that is step one. And that's something that we're tackling. We're actually launching a beta product here in a few weeks. And it's you can think of it as Amazon Marketplace for healthcare. So anybody from physicians, physical therapists, chiropractors, anybody that can provide a solution to somebody's healthcare needs, they can go out there and list their stuff, and people can purchase it directly. So we're doing our part in trying to jumpstart the free marketplace in healthcare. And I think this is something that it's going to take multiple entities like this to go out there and really raise awareness, because I think that's one thing with DPC Mapper, the mapper for DPC clinics. And I'm seeing people on Twitter, LinkedIn, Facebook, everybody's talking about DPC. This sounds amazing. Where can I find somebody, a doctor near me? And people are sharing this link around. And that's one thing that we're going to have to do, is just let people know that something like this exists. And that's something I just want to throw out there that we're going to be launching, just so everybody knows. I know.
That sounds great. I have two questions. One is to David. David, do you see, you're in Washington, are there cracks that you see that we can penetrate or widen to get our foot in the door, aside from just trying to meet with your elected official and give them money? Do you see any openings that you can spread to other physicians, and we can get the word out to our specialty societies, state medical societies? Do you see any strategy there to get our voice heard and break, get back to the topic of our talk, break the stranglehold?
Well, first, let me say I live in Texas, so I don't know that I could ever leave the great state of Texas. I'm currently in Austin, working in the Capitol, but I spend probably a week out of every month during the active session in DC. What can be done? We've talked about a few things. I can't tell you how important it is for physicians to get on the phone with, and for the organization, so your specialty organization, if there's an issue that you care about, have a specific message. I've had many of the congressmen say, if we have 10 phone calls in a day, 10, that's a groundswell. That's what they refer to it as. They're just not getting that kind of volume from us. So having them, and I know we're busy, but one phone call, one email, a letter, have them reach out. I'll tell you this, the subject matter experts in DC, their expertise is pretty superficial. They can't do the deep dive like we can. It's not everybody. There's some that are very brilliant people, but for the folks that are helping these representatives, it may be their first time jumping into healthcare. And so they read and absorb as much as they can. But for us that live and eat and breathe this industry, we understand it at a much deeper level, and they need our help. They want our help, and they've expressed as much as that. So being engaged, being active. So if you have a specialty organization, provide them with the names of their congressmen. Give them a script. Make it as easy as possible. Take a trip out there. Visit them when they're in town. Have them know you by a first name basis. Contribute a little bit to their campaigns, because that's important, because they're getting money from other folks. Get your patients. You shared the story. Get your patients to call. If they express a frustration to you, say, look, I would really appreciate if you called the congressman and shared with them this message and give them the information. Working at the state level is also very important. We talked about that. I don't think we should focus on just the federal or just the state or just the market option. I agree with Brian. Doctors need to break free. And I agree with Kim. We need to work at the state level. And I agree with others of you. We need to work at the federal level. We need to do all of these things. As I said before, our time is short, and we need to be as active and as engaged as possible. I thankfully have the luxury of being able to do this full time, and I'm here as a support for many of you. So please reach out to me with any ideas or thoughts, and if I can do it, I'll do it. But we're stronger as a team and as a coalition than we are as individuals.
And that's great. And as a follow-up to that, going back to the patients, I talked to Brennan when we first chatted about maybe making a 1 or 2 page bullet point list to hand to our patients and utilize our patients as sounding boards to reach out to their elected officials. And I'm just wondering if that's something that you all see as feasible, and we can maybe put together we have a committee now, but put together these bullet points and keep it short and brief, keep it simple, that if we agree upon it, and obviously it's going to take a little work, that we can hand out to our patients. I mean, they sign privacy sheets, they fill out their history. I don't think it's too much to get physicians recruited to hand these out to our patients.
Yeah.
And
I'll say this as well. I'm sorry to jump in there. I think what's important where we get tripped up, healthcare is personal. It's not partisan. It shouldn't be. In this coalition that we're building, we have liberals and we have conservatives, so it's important that we don't make this about politics, and we don't pick on subjects that are clearly more conservative in nature or clearly more liberal in nature. There are a lot of things to fix that we can all agree on. And as I go into Democrats' offices at the state capitol or in DC, I'll say, look, we all want the same thing. We just have different ways of getting there. What are the things that we can work on together that we can agree on the process? And that's a first step. They want to know that we don't hate people, and we revel in the idea that the streets will run red with blood. And it's just silly to hear some of the things that people think that conservatives think. But we care about patients, and I think that's the message that we need to convey.
correct. Absolutely. It's definitely not partisan. In that, if you believe that opensecrets.org website, when you look at the election cycle from 2012 to 2016, if you believe what you read, both McConnell and Schumer took short of $500,000. I don't know from who, from where, from when, but it's easily in the $400,000 range. The leaders of the Senate. So it's all about our patients. And I'd like to use them if you think it's doable. We can talk about this maybe on the next meeting, or we can submit our ideas as bullet points. Again, we'd probably want to keep it short. And this would be a handout that goes to our patients that also instructs them on how to reach out to their elected officials and tell them what they would like to see. If Humana, and I'm not picking on Humana, even though I hate them, but if they can have these nice commercials, with Mr. and Mrs. Smith looking healthy as can be, of course, right? And blowing smoke up their and trying to sell them an insurance policy. And then once they sign up, forget it. Everything's denied. They don't know who's doing what. They have copays every time they see a doctor. It's a mess. So if they can do that, we have the patients right there. They're in our rooms. We just shook their hand, and we have total control of them right then to use them as not only our advocates, but as their own advocates, because they're sick and tired. They're really frustrated and they're angry, So send them to Brian, but they're upset and they take it out on us. We're the only ones that they see. So we need to use them to our advantage.
Yeah. One thing I'm muted. Now, on that note, Ernie, I think we should get together a shared document, kind of what you're talking about, a bullet point. And what I was planning on doing is typing up a brief or the start of a Google Doc, and I'll share that with everybody that was part of our talk today, and we can collaborate on that. Add your bullet points. We can add comments, suggestions, and this could be the start of a collaborative document that we can all work together on. Something that could be shared with the public, make it completely open. You get feedback. I don't know if anybody's ever been a part of something like that, but there's a lot of white papers out there for different technology projects, and you'll have hundreds and hundreds of people, different developers chime in saying, well, you need to change this, you need to change that, edits, different things, different sources, citing references and stuff. And it's amazing to see it all come together. So something like that for the beginning of talking points or a plan like this, I think would be beneficial. And I think people can just sink their teeth in, actually grab hold of and take off and run with it. So I'll get that together and I'll share that with everybody after this.
That'd be great.
Yep, and then I would just throw out there, we live in a world of lots of dopamine. So when it comes to social media, when it comes to entertainment, the more dopamine you can release, the better off you're going to be. So that's where you see all the bells and whistles, and if it bleeds, it leads, and that sort of thing. And so at the end of the day, healthcare and healthcare reform, healthcare finance reform, none of this stuff is sexy. It's not all that interesting in the grand scheme of things. And so I think that we lose a lot of our momentum because there are so many other distracting things that are out there, especially on Twitter or otherwise. And so I love the idea that citizen health is that you're willing to kind of put your money where your mouth is, because it takes a lot of time to coordinate things and to follow through on things and follow up on emails. And a lot of that stuff goes uncompensated, which again comes back to having an administrative infrastructure to get stuff done. And so I appreciate what you're doing, what you're trying to pull off. When David and I we know and have connections with the group Practicing Physicians of America. And they have very big goals and very big plans. At the end of the day, it comes down to that administrative function. And so we're donating tons of time, but at the end of the day, it's, who's managing the email marketing, who's managing the social media, who's doing those things, because in a world where there's just so much data and so much information, we can't get anything done unless we put more effort there. I talked to a guy with a nonprofit, and he said that in order to get kind of the marketing message out across America and get it above the din of all the other stuff that's going on, it would take $1 million just to do that, just to get, physician autonomy, or just to get a single short message above all the rest of the stuff. I'm not saying that to be discouraging. I'm saying that that's what we need to shoot for. So be it citizen health, be it whatever you're doing, you have to, we're going to have to infuse it with capital, and we're going to have to get that capital from somewhere. I don't know yet, but I mean, it's going to happen, or the whole damn system will melt down, and there will be blood in the streets. No, I'm kidding. But we have to do something. And I appreciate what you're pulling together right now.
Thank you. Thank you. It is difficult, and that $1 million price tag, it's probably a low number if you want to get down to it. And that's something we're trying to do. And the whole reason we called it Citizen Health was to be generic as possible, to try to be all encompassing the citizens health plan. Yeah. And it's something that I've been thinking about to raise money. We don't want to go the VC route because different agendas there. But I've really been looking at cooperatives, and I love the model of cooperative. And we could do that. And that is actually some of the plans we're kind of working through now, talking with some attorneys, but turn this initiative into one large cooperative where people that do want to see change, they can actually become a member, and they can actually get their voice heard through a vote in the direction of what we're doing. They can also fund this. So it's like you got skin in the game, you got a little equity in this. So you got a dog in a hunt and make it actually work out. And you're more apt to say, yeah, I will share this on social media. I'll chime in. I'll give my 2 cents. So that's a direction we're heading. And I think it feels good to me. It feels right to go that direction. Like I said, we got to work through some things, and just some ideas I'm throwing out there if anybody else wants to chime in on that direction. So.
Well, let's keep the momentum going, and let's keep moving forward here, and not make this a one-hit wonder.
Yes, I do agree. Momentum is key in this.
I don't know if it was a one-hit wonder today, but I certainly enjoyed it. But let's keep moving it forward and try and take it to the next level.
I do agree, because a lot of times on Twitter, you see all on social media, people are all talk, no action.
Right.
Definitely don't want this to be just one of those things. So we got to keep this momentum going, like you said, and actually start putting something in action. I do think putting together a document that kind of sums up what we're talking about today, that's action. We can start building off that. So let me start working on that. We'll get that out and just continue moving forward. And I think today it's about 2 hours, so that's a good time. And next, let's just try, if this works out for everybody, Saturday morning works out fairly good for me. So we can keep it on Saturday morning, the first of the month, first, second, third, whatever the first Saturday is, and I just roll with it.
That's great. Brennan, is there a way you can copy what's been going over the chat and send it out to us?
Yeah, I can do that. If anybody has any more comments or questions, let's go ahead and hear them. Or if not, I'm just going to stop recording right now. All good? All right, I'm going to stop this recording. Let's see here.